Greetings. My name is Zaria, and my partner Shelby and I will be presenting our postpartum depression literature matrix. Our objectives and goals include one, synthesize current research from 2020 to 2025 on postpartum depression prevention and treatment, identify behavioral, pharmacologic, and technology-based interventions that enhance maternal mental health outcomes. Three, examine how cognitive behavioral therapy and other health-related models influence recovery. Four, highlight lifestyle-related factors such as physical activity, diet, infant feeding, and social support in moderating PPD risk. Explore gaps in access, disparities, and continuity of care in PPD prevention and treatment. And finally, six, provide evidence-based implications for public health practice and policy focused on maternal well-being. We'll start off with an overview of postpartum depression. PPD affects about 1 in 8 women globally, typically developing within the first year a woman is in postpartum. It's characterized by persistent anxiety, sadness, fatigue, guilt, and overall difficulty bonding with their infant. It's also influenced by hormonal changes, psychosocial stressors, and other pre-existing mental health conditions. Risk factors include low socioeconomic status, lack of partner support, prior depression, and obstetric complications during labor. Untreated PPD can lead to impaired infant attachment, delayed developmental outcomes for the child, and maternal morbidity. Despite increased awareness, screening and follow-up remain inconsistent, and particularly it affects marginalized groups of women, such as minority women. Recent innovations emphasize that preventive interventions during pregnancy and early postpartum are key. Our methods were conducted during an integrated review of 30 peer-reviewed articles, meta-analysis, clinical trials, and public health reports during these said dates. Our databases include PubMed, PsycInfo, and Google Scholar, using keywords such as postpartum depression, maternal mental health, and prevention. Inclusion criteria included studies published between the said dates, focuses on prevention, intervention, and treatment of PPD, and the population being pregnant or postpartum women who were either equal to or greater than 1 year of postpartum. Or less than 1 year postpartum. Exclusion criteria include non-English studies or non-maternal mental health topics, and the data synthesized to identify intervention trends, significant outcomes, and public health implications. Its framework guided by the cognitive behavioral theory and other health promotions perspectives. The overview of the significant findings we'll be discussing are technology-based interventions, alternative medicines for PPD, family planning and labor delivery, cognitive behavioral theory programs, infant feeding methods, and impacts of physical activity. Starting off with technology-based intervention, during the articles that we reviewed, we found that eHealth and mobile app programs demonstrated a high comparison of outcomes compared to in-person CBT programs, which enhance the accessibility of these women participating. Telehealth and smart-based phone programs increase overall participant engagement and adherence to wellness behaviors, a key in accessibility. We also found that alternative medicines for PPD, were significant. Emerging pharmacologic innovations such as zuranolone, which is marketed as Zurzuvae, is the first oral medication approved by the FDA specifically for PPD and shows rapid symptom relief within days, compared to traditional SSRIs, which require a longer onset period to be effective. There we also found that steroid-based therapies, including the zuranolone, but also brexanolone, act on GABA A receptors, which will help to restore neurochemical balance after childbirth. This evidence also suggests that improvements happen with anxiety, insomnia, and mood regulation for women experiencing PPD.
Now that we've looked into the medications, we'll now go into the family planning and labor delivery impact on PPD. In the articles we reviewed, stress and difficult childbirth increase the risk of postpartum depression. Furthermore, less effective contraceptive use was associated with increased risk of PPD. Medications during the prenatal and labor periods should also be considered. SSRI use is a new conversation of how that impacts the mother's mental health as well as the fetus's health long term. Pain management and medications used for that are also important in preventing PPD, while epidural use had no significance between the risk. Next, we'll go into the cognitive behavioral theory. As many of our articles utilized this theory in their interventions, it was associated with lower rates of positive PPD screens. With this, though, however, early intervention matters. No matter if the duration is from 1 day to 9 months, starting early had a positive impact. Early meaning prior to childbirth. These programs also used a mix of technology versus in-person programs or both. Infant feeding methods is another important factor, as there's a correlation between feeding method and the risk of depression and depression levels. So self-efficacy in breastfeeding, exclusive breastfeeding, and skin-to-skin contact all had associations with postpartum depressions, and increases in these factors lowered the risk of depression. Furthermore, breastfeeding support groups were associated with less PPD symptoms, and furthermore, if they were led by a midwife. Next, we have the impact of physical activity. The articles we reviewed had a mix of whether or not this impacted PPD or not. However, it did lower perceived stress. With physical activity, other factors should be included here, including nutrition, stress, and relationships, to name a few examples. And there are ongoing studies on this topic, and one of them relates to e-health platforms or implementing physical activity and technology. So here's the method of the study. There's no results out yet, but it'll be interesting to see, especially at this 12-month mark, how the merge between physical activity and technology will impact the risk of postpartum depression. Looking into the AI tools and applications of postpartum depression, we did have various studies that implemented technology-based programs, and they may just be as effective as in-person educators to help us meet that demand. It's going to be important to target the peri and postpartum period for depression, implementing exercise and other health promoting behaviors. And it is still going to require some guidance from in-person educators to encourage completion of the programs. So what does all this mean for the field of public health? And it comes down to that addressing postpartum depression is multifactorial. We're going to need to really focus on family planning resources and support, supporting the maternal well-being overall throughout pregnancy and postpartum, utilize technology-based interventions, and then use the newer pharmacological treatments under extreme caution of healthcare professionals. So recommendations going forward, we should be using technology and AI-based tools to reach mothers at every phase of pregnancy. Starting early, again, here is key. And implementing programs based on cognitive behavioral theory has been found to be successful. And we need to address depression and lifestyle factors altogether to support the mom and baby. So again, thanks for listening to our presentation on postpartum depression and our literature review. In the following slides here, I have our references. So that being said, we look forward to hearing your feedback and appreciate everything you have taught us throughout the semester so far. Thank you.